Good morning, everyone. Thanks for coming to Grand Rounds today. Before I introduce our speaker, Dr. Negley has a couple of things he'd like to say.
So I know that we don't have the full complement here, but as most of you may have seen in the paper this morning, Children's of Minnesota and Blue Cross did not reach agreement at their regarding their contract. So that means as of this moment, Blue Cross Children's is out of network for Blue Cross. This is going to put a fair amount of pressure on us. At any given day, there are 96 kids in the hospital at Children's that are Blue Cross Blue Shield patients. This building holds 96 kids. So this is, there are a few things that we can do to help with this. For those of you on running inpatient services for our residents, think in advance, think a day or two in advance, start planning discharges. If we can move our discharge times up into the morning from the early to mid-afternoons, that will certainly help free up space. If you're in the clinics, you're going to be seeing communications from Dr. Schwarzenberg and from Beth Andrews regarding some changes we may be wanting to make in clinic schedules to accommodate these patients. I think we're going to see the biggest influx in the clinic first. New appointments will be pushed over here from children's specialists. And be patient and be calm. It's going to be stressful and busy for everyone. So, and if there are questions, get a hold of me, Abe Jacob, Sarah Jane. All of us do everything we can to help. And if you're in the ED, just God help you. No, the ED is... The ED should be able to handle capacity for a while. At least this is happening in the summer and not in the middle of the winter. So that will help a bit. So John?
All right, thanks, Joe. Delighted to welcome my colleague Mojca Konia to deliver Pediatric Grand Rounds this morning. Mojca is from Ljubljana, Slovenia. How'd I do? Well? Okay, great, thanks. And but has done much of her training in the United States. She spent some time in California at UC Davis. She's now the Vice Chair for Education in the Department of Anesthesiology and also runs the residency program in anesthesiology. More recently, she's taken over leadership of the Simulation Center in the medical school and is here today to talk to us about the use of simulation, which is growing in our educational programs, and some of the practical implications of simulation use here at the University of Minnesota. Dr. Konia?
Thank you very much. It's a pleasure to be here in presenting the Grand Rounds. I'll talk to you a little bit about teaching with simulation, the pros and cons. I have no disclosures. Sometimes I wish I had some, but I don't. And I just want to sort of see, I know I've been working with Mark on simulations that are happening in the ER. Anybody else works with simulation, has educated with simulation? Yes? What have you done?
We're residents, so we do the simulation.
Okay, great. Back there, Ashley, I think? Okay. Okay, perfect. And you also have Dr. Pitt, who actually published recently on simulation in global health. What I plan to do today is review the simulation environment at the university with you a little bit. I want to present to you SimPORTAL. What is it? What do we do? How can you engage with us? I'm going to describe a few sort of things related to education with simulation in medicine, which I think are important, some of the principles and theories behind it. And then I'll give you a little glimpse into what the plans are for the future of simulation at our institution. We're in the process. We actually did receive funding for a new building that is planned to go up by December 2019. It's planned to go up where the Masonic Cancer Center is right now. And the legislation of the state has supported the funding for it. So plans are in the works. So the current environment of simulation in the university is pretty complicated. There's the Nursing Benson Center. That's a simulation center that's beautiful. It's just gorgeous, a lot of space. fraught with the problem that they do not have anyone to do with any expertise in simulation to do anything in it. So they rely on other people to provide support. There is the Dentistry Simulation Center. That is a very intensely utilized center. The dentistry school uses it all the time for their education. It's kind of cool. It's pretty impressive to visit. Pharmacy has its own simulation center. It's really just one room and serves their specific purposes of mixing drugs and things like that. Vet school. Veterinarians have their own simulation center. It's on a St. Paul campus. And they are actually willing to interact with medicine people. So if anybody has any needs or desire to engage with them, they're open to that. And then there's the Academic Health Center, Simulation Center, which is located in the PWB building. And supports basically anyone interested in doing simulation. It's a fee-for-service type of environment. So if you want to do something, you have to apply. They will give you a bill. And if you're willing to pay it, they will do it for you. And then there's the SimPORTAL, which is the Medical School Simulation Center. And I'll talk a little bit more about SimPORTAL, but it's basically financially supported through medical school, and the funds come from medical school. So SimPORTAL is where I work. It's located on the 5th floor of the Mayo building, and it's specifically a medical school simulation center. It has a mission of being leaders and innovators in healthcare education, assessment, and research utilizing simulation technology. And our goal is to optimize competency-based learning, longitudinal student outcomes, and patient safety. The team is small. Amy is an ER physician. Dr. O'Neill has graduated from Simulation Fellowship, and she is our main person to help with assessments. So if anyone were to want to do a simulation with us and wanted some help with developing the curriculum and assessment, she'd be the person to reach out to, and she would provide all the support you need. Dr. Acton is a surgeon. I'm sure you all know him. He is the director of the Simulation Fellowship, which SimPORTAL provides. And I'll talk a little bit more about that in just a little bit. Dr. Molina used to be our simulation fellow and is currently hired by us to support our research missions. And then we have administrative support. Nick does a lot of coordination, which is necessary for SimPORTAL to work properly. Jonathan and Jason are techs that support any activity and would come to you, like they come to the ER here with all the equipment and support it, or they come to NICU. And then we also work with students a lot, and they provide a lot of support. We train them in, and then they're oftentimes become pretty independent. The organizational structure, a little fuzzy. That's usually the case with organizations. Anyway, we live in the Office of Medical Education. My immediate boss is Dr. Rosenberg. We do have clinical directors, which are faculty members that have been intensely involved in SimPORTAL. And then we have a curriculum assessment council, which kind of tries to prioritize which activities we can and cannot support, and then the rest of the support structure. We are accredited by American College of Surgeons as a simulation center and by the American Society of Anesthesiologists. These are accreditations that you have to apply for. There's quite a lot of paperwork, and kind of like an ACGME application for residency, sort of involves lots of documentation and proof of you being able to do certain things. We have to recertify every 2 to 3 years for each one of those, and we've just gone through the cycle last year. We also are accredited simulation fellows through fellowship. We also have accredited simulation fellowship through the American College of Surgeons. Actually, University of Minnesota was the first site where such a fellowship existed. I started in 2010 under the leadership of Dr. Sweet. with the intention of creating international leaders and in surgical simulation and curriculum delivery. We take one applicant every year. It's a 1 to 2 year type of a program, financially supported, and allows the individual to basically learn about how to create curriculums. They also have to design a simulator, whether it's virtual reality or actual physical device, doesn't matter. How do we prioritize the curriculums? It's basically to a large degree determined by how we're financially supported. As I told you before, medical school basically pays us, so clearly we have to deliver medical school curriculums as they come to us. The next priority, which Dr. Andrews is very supportive of, is that any GME activity that is required by the ACGME is also supported, and the Dean and Dr. Rosenberg are in agreement with that to support those. The next priority for the medical school is multidisciplinary skills and then team training. The financial sort of structure is the money we get from medical school, the grants, donations, industry support. We also can run things like CME activities, which are revenue creating activities, and we usually do those on the weekends so they don't interfere with any of the curriculum activities. So how would you come to us, and how would you be considered to do an activity in SimPORTAL? The process itself is not too complicated. There's a course proposal form that's easily accessible on the website. You fill it out, send it to Nick Newman. All these instructions are on the website. And then your proposal gets reviewed by Curriculum Assessment Council that consists of several individuals from the Office of Medical Education, GME office, and SimPORTAL. And basically, the decisions that are being made are how applicable is your curriculum to a variety of learners. It's much easier for us to advocate for a curriculum that is appropriate for medical students, as opposed to something that's very sort of narrow and directed towards just a few maybe residents or a very subspecialized area. So the curriculum gets reviewed. You also are provided help with maybe some adjustments to the curriculum, and then the decision is made and you're informed about it. What are the programs that are running? Medical school, surgery, anesthesia. We do EPAC curriculum. PEDS ER is doing sessions regularly. NICU is doing sessions regularly. Emergency medicine, urology, internal medicine, and those are all activities basically that include a variety of learners from medical students, residents, through fellows. We try to make, if we can, we will try to support you. We do get asked questions about where our people are and what they're doing. Going through the official process is important. What people have done in the past is, if it's activity that's specifically related to residents only, for example, obtaining some sort of a grant always helps, because we can at least advocate for partial support of an activity if it's a very specific area that you're trying to address. We do train-the-trainer sessions as well. They're intended basically for anyone who's interested in learning a little more about the education, and specifically education with simulation. And we try to go through a little bit of education theory, a little bit of pre-briefing and briefing components of it, which I think for simulation are extremely important piece of it. We go through the development and implementation of simulation curriculums. Assessment, I think, is a piece that we tend to forget a little bit or push to the side, but I think it's very important, and it needs to contain learners, instructors, and coursework assessments, and then techniques of good feedback. So we try to go through a lot of things in a 2-day course. It is a CME course because, you know, if you're going to dedicate 2 days of your time, I think we have to give you something back. And it's being sort of revamped and will be offered this autumn. So if anybody's interested, please join us. For now, we're going to basically carry the cost of it. So it'll be for our faculty members, it'll be free. In the future, we'll have to see. It's a constant discussion. Currently, we do 2 types of CME programs in SimPORTAL. Maintenance of certification in anesthesia is basically an anesthesia board included simulation as part of the recertification process. So every person has to go through 2 sets of simulation courses, which is a day activity with 7 scenarios. We do those for basically offered nationally. We've done probably 12 so far, and it's going really well. And people actually, once they overcome that initial fear of simulation, enjoy it. And it's a fun exchange of experiences. The anesthesia board for now, it's not making it a test. It's more of an interaction between providers from different hospitals. It's really interesting what you find out and what you learn about how people do things. Sometimes very helpful, and you can introduce those things into your own environment. FATE course is the transthoracic echocardiogram course, which we offer to anyone interested. So far, we run 3 courses, and it basically provides just basic understanding of TE with the intention of being able to recognize the major causes of hemodynamic instability. It's not a detailed echo course. You're not an echo specialist, but you would be able to recognize regional wall motion abnormality to determine that ischemia is causing your hypotension, things like that. This is applicable to students, residents, faculty, whoever's interested. Our research areas are development of simulators. We work with Medical Device Center, who helps us with development of physical simulators or virtual simulators. It's a very interesting environment, the Medical Device Center. Recently, they've helped us with some 3D printing of certain anatomies that were very helpful, and virtual reality imaging of a 3D anatomy of a child, which was very helpful for the planning of surgical procedures. So it's kind of cool. We are working on predictive education modeling using computers to actually recognize learners in a simulated environment that are struggling, basically just finding the outliers. Human performance in medicine, data warehouse programs, and train-the-trainer programs. So a variety of things. So that's the SimPORTAL. Any questions? Okay. If not, then I'm going to move on to, yeah.
One quick question. What's the approximate number of requests you get? How likely are requests to be funded for courses or projects?
So we get on average 10 to 12 full requests per year. And then it'll depend, the likelihood of getting funding from medical school depends on how intense the involvement of medical students would be. I think you can always write the curriculum in a way that would apply to medical students, and if you're able to include them into the activity, I think then we can vouch for the support. But it's much more likely to get funded if medical students are one of the target learners.
So, just to add to that, there's been a dramatic change in the ability for programs like ours to do simulation. So about 7 or 8 years ago, a group of us went to the SimPORTAL.
Yeah, thanks. So I just wanted to emphasize how different things are now and how much more positive and accessible the SimPORTAL is. 7 or 8 years ago, we went through this process and had no funding, and it fell flat. And at this point now, under our new leadership, I think that there's a greater emphasis on bringing SimPORTAL and the simulation experience to each of the departments of the medical school. And our program, we have medical students, but we don't feature them like we do. I mean, it's more of a broad-based approach. And we do have some funding, and so we've partnered with SimPORTAL to use a little, our donation from the Hubbard Foundation with SimPORTAL resources to make our program. And I think that it's been really very successful, and we greatly appreciate the support from SimPORTAL.
Thanks. Oh, I will get going into a slightly different direction now. So I'll talk a little bit about teaching with simulations and what are some of the pros and what are some of the cons. And I guess Goethe said it pretty well. It applies to the simulation perfectly. Knowing is not enough, we must apply. Willing is not enough, we must do. Why do we want to engage in simulation, or how did it come to being more emphasized as a tool in the education world? I would say the amount of information is just exploding. And it's really hard for a medical school educator to remain current and to be able to transfer all the information that's coming out every single day. The problem of patients being more and more concerned to not being practiced on is becoming more and more prevalent. So it's, my time, there was no question. You were in a teaching hospital, things got done on you, and you were told that too. It wasn't a question. I think at this point, combined with some of the legal issues related to medicine, it certainly is no longer the case where we are just doing it. Simulation provides an environment where you can do a lot of things safely. The hospitals are emphasizing patient safety and quality. That's something that we have to do. It's something that's imposed on us, and we have to demonstrate that we're successful, and that's also one of the driving forces. And simulation is not only a tool that you can use to teach learners, it's also a tool where you can test environments. You can test the safety of, let's say, since I'm more familiar with that environment, you can test safety of a new OR with a simulator, with high-fidelity simulator dummy. They do that in a lot of hospitals. I know, like Kaiser in California, that's what they do. Every new site that opens is basically tested with high-fidelity simulators for the safety of that environment. A duty hour thing, it's now, for us, it was new a while ago. For the current residents, it's like, what are you talking about? That's what it is. But it is true that it does break up your learning experience to a degree and prevents continuity. And we do hear sometimes comments from people that they don't feel fully prepared, especially for certain of the skills that are necessary for you to practice confidently. Simulation is good because you can teach knowledge, skill, and attitudes with it. So it doesn't just address one component of knowledge acquisition, it addresses several. In the 90s, early 90s, Institute of Medicine basically suggested a simulation as one of the bridges to overcome some of the challenges that we're facing, and that's when simulation really took off. What are some of the types of simulators? Hold on. So we have standardized patients. You can role play. Demonstration is a very easy one. We do this all the time. Screen-based video games, partial task trainers, full environment simulators, basically simulations of or training of interpersonal and communication skills. All these things can be done. So it's not solely that thing where you have like a central line model and you stick a needle in and you try to teach a central line. It can be a lot of other things. You already seen that. This is a guy in Boston who just loves to intubate himself. So residents love it. But basically, he demonstrates how to do an awake fiber optic intubation. We do this every day in the ORs or in your own environment, so it's obviously something we're very comfortable with. The only problem with it is that sometimes if we just do it, we forget the piece of what is the message that we're actually trying to transfer and how we're going to assess that we've actually achieved what we're trying to demonstrate, and the learner is going to actually see that. Another simulation thing are screen-based video games. They can be used very well. In reality, they look a little more like this, but basically you could do the same thing with problem-based learning type of activity, except that this development of this is probably much more expensive. So, there's pros and cons. It does allow the learner to do this on their own. So if you're dealing with large learner groups like medical schools do, that's probably appropriate. If you have 3 to 4 residents probably developing this whole thing, because there's a lot of development that goes behind, is probably not the best investment of the funds. Partial task trainers have taken off very heavily once the endoscopic surgery came along. The challenge of endoscopic surgery is that you're moving from a 3D environment into a 2D environment. Plus that when your hand moves right, your instrument moves left. So you're basically having to relearn your brain of how it processes information. And for that purpose, something like a task trainer is very, very good, because you can put a learner in there for many hours and they will improve their competence, their operational performance, and we now know that it does transfer into patient environment as well. Then we also have the full environment simulators. This is what we also call high fidelity simulators. These are things, they come in all sorts of sizes, from a neonate to a full size, adult size simulator. And they'll have lots of different physiologic functionalities. It usually will function with a technological support, so you need somebody who's able to operate the computer behind it. As Mark knows well, there's lots of little glitches that can happen, like the internet sort of connection is not the right one, and if you have to troubleshoot these things on your own, it's probably not going to work well. So having technical support for this type of simulation is very important. How can we use it? What is it good for? Certainly skill instruction is one thing which it's been used for decades. I think the very important component of it, which you need to take advantage of if you're going to be doing it, is the actual active learning and immediate feedback. If you just do the activity and no feedback occurs right there on the spot, the outcome or the desired outcomes are not going to be reached. I've talked a little bit about the safe environment thing already. What it does also is you're potentially training a high acuity skill or a high acuity sequence of skills in an environment where errors are okay, where you can correct them and practice again and again and again until you get it right. It's ideal for promotion of teamwork and communication. And for example, when I talked about the MOCA recertification component of the ABA recertification process for anesthesiologists, the major thing that they want us to address is the interpersonal communication piece and the leadership piece. which simulation, especially the high fidelity type of simulation, I would say is ideal for. It also works for consolidation of knowledge. It's interesting when you put an actual full-blown faculty member into an environment, a lot happens and people still learn. And I think for that piece, introduction of simulation into the anesthesia board recertification was important. Even though there was, of course, lots of complaints and people were like, I'm not doing this, it's too expensive, and I don't want to do it. But at this point, any person who comes through these courses actually enjoys them and thinks they're of value. And I would like to re-emphasize that you can address knowledge, you address skill, and you address the attitudes with it. So you're getting all three components as opposed to some of the, for example, what I'm doing right now to you is just some sort of didactic thing which activates a very small component of you. And after like 15 minutes, all of you are asleep anyway, so it doesn't matter. A big component of how simulation events are structured is based on some of the theories of safety management. They basically base their major premises in the high reliability organization theories, which basically state that adverse events require several components. And you're all very familiar with the Swiss cheese model and the holes align and then an accident happens. But basically what they're talking about, you have organization which has its own processes that, underline the assessment, organization patterns, how it's managed, how it's designed, how it's built, how it operates, how it's maintained. So all these things are part of the, you could say, organization culture. And there's always going to be some latent failures within that. It's a big organization. We all know, like we complain about it. Oh, Fairview this, Fairview that. That's that component. There are certain things that are done a certain way, and they may have some issues in it. The second one is sort of immediate environment in which you find yourself. For me, it's going to be the operating room. And within it, there's certain conditions under which I have to function. Maybe it's how the add-ons are introduced into the OR, something like that. Something that will create certain conditions that require a response from me that may potentially lead to error or even violation because I'm either pushed to do something that I don't want to or some other thing is present that could potentially lead to a problem. And then there's us, the individuals, and we are all error prone, and sometimes we violate things as well. And those are just active failures. And if you have all these three together, that will eventually lead to accident. And simulation has been identified as a tool that can basically address all of these different components. We mostly think of it as the tool that addresses the individual. So we're wanting to teach with it. However, we can put it into the environment and identify things. It was interesting. A few years ago on the East Campus, we did a airway fire simulation in the operating room environment. And it was very interesting to, we presented the scenario. We didn't tell anyone what we're going to do. It was an ENT surgery. Everybody thought it's going to be an airway fire. So everybody was preparing for an airway fire in their own way. But through the simulation, as we threw little bits of things, it's a sedation case and it's a lymph node right here and the guy is sick and he can't lie flat, so he gets antsy. Then he gets chest pain and starts reaching up. Before we knew it, we had perfect conditions for airway fire. And it happened. However, an unexpected thing happens too. Somehow the airway on that particular simulation became difficult. That was unintentional. We did not plan for that. And the process led into an emergent cric. There was zero communication between anesthesia and surgery team about when the cric is going to occur. They were all doing their own things, living in their own little world. You know, there's that blood-brain barrier. And they did not communicate. And that was very obvious to both teams immediately after as we were watching the video. And it initiated certain conversations which previously have not occurred. So it was a very, very interesting interaction. So I would say simulation can address many, many different things that you don't necessarily anticipate. And I would say for that reason, many institutions in the country are using it broadly in the hospital environment. And I think we can certainly improve on that. So the underlying sort of premise behind the teaching with simulation is the concept that this is Miller's pyramid. Those who are in education are probably very familiar with it. And it basically introduces 4 stages of knowledge. He called it knows how, shows how, and does. There was a guy by the name of Eisenberg who built on that and basically tried to give it a little more meaning relevant to simulation. And he calls the level self-efficacy, which is the knows. So I think I know how to do this. Competence, where I go into the sim lab and I show, yes, I know how to do the A-line. Operational performance would be something where I go from the simulated or teaching environment, whatever it is, into actual clinical environment and show my mentor how I'm going to do this. And the final level is where you're able to actually modify your behaviors based on the patient to achieve better patient outcomes. So this is where simulation comes into play, where it tries to push regular lecture series, basically only stays at the knows level, maybe goes up to the knows how in the PBLD type of sessions. Anything beyond that is impossible to do in a didactic type of session. Simulation can do it. Another premise that's very important for simulation, and I think for all of us in this environment, is that we're dealing with adult learners, which are different from, kids, 7-year-old kids who will do sort of, or mostly will try to do what we tell them. These are adults who have their own understanding of where they are. They need to know why they're learning. And I know for myself that I frequently fail to communicate to them well of why is this so relevant? Why am I talking to them about or showing them a certain thing? If you can do that, the engagement you'll get, if you provide the relevance to it, the engagement you'll get is going to be much more. PBLDs, simulation, anything that induces problem-solving activities is going to be much more engaging. You're going to, again, activate people, and that's very important for an adult learner. Okay, here we are. Each one of them comes from a different environment. Some of your residents might have done another residency, and then you go to the basics of a certain, blood gas, and they know it well because they've done medicine before they came to you. You have to know where they are. You have to know who they are. You have to teach specifically to them. I know that's hard. We have a lot of learners. It's probably easier for me. I have 7 residents only. I know it's much harder for you. You have many more. But I think all this will lead to active participation, which ultimately leads to a much better outcome. So you get more for your investment out of an active activity than out of anything else. A big component of simulation is also clinical skills learning. Clinical skills are a composite of problem solving, communication, technical skills, and complex medical context in which a learner finds themselves. You know, we all know that being sort of solving a problem on paper is much easier than when you actually have to solve it in the environment in the hospital. And for an expert to be created out of our learner, we have to do 4 things. There has to be repetition. And repetition can be either in the clinical environment, or it can be a combination of something like simulation and clinical environment. And probably because of the limited hours that learners are in the learning environment, things like simulation and whatever else we can think of are becoming more important. The assessment piece is extremely important. You have to assess whether you've achieved what you aimed to achieve. You will not know unless you, in some way or manner, ask that question. And maybe next time you'll have to modify your activity based on that. Because I know that I've done simulations with my residents and I'm like teaching them stuff they know, so it's boring to them. But I identify things that I thought they knew, but they had no idea about, so that you can modify your activity based on that knowledge. You have to provide feedback, and this loop then kind of ends up in improved performance. So what I'd say, and you know, in terms of improved performance, we now have pretty good evidence that that is the case. Wayne did a study where they trained ACLS for 14 months, and they have shown improved outcomes in the hospital. They trained residents, and the compliance with ACLS and retention of skill was significantly improved. So it does work. So what are the pros? Well, self-efficacy, I spoke about it a little bit already. That's like my own perception of how I'm doing. And oddly enough, somebody with limited knowledge will assess themselves much higher than somebody who's a real expert. The real expert doubts themselves a lot because they have a lot of knowledge to understand that they don't know everything. Beginners tend to overestimate. So asking a question, well, do you feel like you know this now, is not going to give you much information, because a beginner will much more likely say yes, and somebody who actually probably knows it will much more likely say no. So it has limited benefit. We ask it anyway because it's important for us to know if something appeals to a learner or not, if we want to achieve good outcomes, but it's not a very good indicator of whether competency has been reached. Competency is the thing that demonstrates this to me in this controlled environment, whether it's simulation or whatever, and that we can do very well with simulation. Improve operational performance is basically transfer to the patient care. That has been also well demonstrated. For example, I'll go back to the endoscopic surgery. There's numerous studies demonstrating that operational performance, so transferring to clinical environment, is real. Residents do better, they operate faster, they make fewer mistakes. And ultimately, we need to make sure that patient safety is increased, and I'll show you a slide that demonstrates that we now have enough studies to support that notion. How does it work? How does simulation as an educational tool work? It provides concrete experience. It provides observation and reflection. That's the debriefing part of simulation, where after you've completed the activity, you take the recording of it and you look through it with the learners. It's impressive the impact that can have. Because when you go through it and ask them, so what were you thinking here? What were you doing here? You may have assumed something. The story may be drastically different, and your discussion based on that is what really drives the learning experience in the simulation. It gives sort of, you give them time to think about it. If they feel a little exposed, it's okay, because that'll make them think a little more. and when you bring them back the next time, they will come back with some better preparedness for that, and they can try it out again and see if it works, and then it's kind of like a closed cycle. So what do we use it for at our institution? We're training emergencies, we're training teamwork, we do skill training for novices a lot. I think it's important that it allows for error discussion without punishment. I think that was, for example, even for the ABA, a major driver for not making the simulation a test component of the recertification. It's just you have to do it. It allows for testing of new procedures and new devices. Lots of LMAs, for example, an airway device, were tested in simulators. It allows for evaluation of competence, and it's been used broadly for that. And it allows for study and investigation of human performance, which has many components to it that, you know, I'm starting to just understand little bits of it as I'm reading about it. Does it work? This is a systematic review, and he's got much more studies in the article where simulation is compared to no activity. This is just a component of the study, and there the impact is moderate. For the studies that compared some other learning activity to simulation, the effect is small, but it's there. I feel that probably for us, we have some of the best learners in the environment, so they'll learn no matter what we do with them or to them. But I do see a value of simulation, and I think it's been recognized nationally. There's also, of course, two sides to the story. It's costly, it's time-consuming. You have to, you know, development of curriculum does take quite a bit of time. You need people who know how to use it properly to actually get the results that you want. Otherwise, you're probably wasting your money. And the goal needs to be to improve patient safety. That's a task that we've been given by Institute of Medicine. So if we're going to do it, our ultimate goal needs to be transfer into the patient care environment. And just to give you a glimpse of what a design should look like. So you need to determine the need. The needs assessment is a crucial component of this, and that will help you identify the gaps. If you don't do it, if you just think of something, oh, I think we should teach that, simulation is probably not the right activity. You really need to plan for this. Goals and objectives, all of us that are in education are annoyed by them, but they have a significant meaningfulness for this because they guide your activity. You need to really define what it is that you want to teach. Feedback, I mentioned, as an important component of it, and then assessment, not just of the learner, but of the program itself and of the instructors. If you're not going to do assessment, you're not going to get the results you want. So assessment, assessment, assessment. That's it for the simulation. Any questions at this point? I just have a little more about the future. I'll just get into the future and maybe take questions at the end. So this is the grand new building. I told you where it's going to be located. It's a 5-floor building. 2 of the floors are committed to simulation. 1 floor will primarily support the standardized patient type of activities. The other floor will support any sort of more like we call it in-hospital type of simulation activities. It'll have 2 operating rooms, 2 emergency rooms, 1 trauma room, and a number of inpatient type of rooms. They're all modifiable to whatever type of activity you need. So I think it'll provide for a much better environment. The intent also is to basically bring academic health center simulation and SimPORTAL into one space and create a new entity out of it, because it really makes no sense to have two simulation centers that in a sense support all of it. It causes fragmentation also, because if we as an institution want to push interprofessional training, we can't do it in this dispersed environment. So basically, the intent is to create one single SIM center. The vet school, the dentistry, pharmacy, nursing intend to maintain their own simulation centers because they support very specific things that are relevant solely to their specific learners. But the rest of the activities will occur under the same roof with the same team supporting everything that's happening. Just to sort of sum it all up, there's a variety of simulation options available. We support majority of types of simulators in SimPORTAL. We have opportunities for grant proposals that lead to a purchase of a simulator. For example, one of those was cardiology, surgery, and anesthesia applied for TEE simulator and received the grant, and now we have the TEE simulator in SimPORTAL, which is probably one of most utilized simulators. It doesn't do just TEE, it does transthoracic echo as well. So there's opportunities, especially if you can pull together a team from several departments. It can be used for a variety of things. I think the communication part and crisis resource management, it's perfectly designed for. I would like to emphasize an institution, we need to start using it in study of our environments and our team interactions. It provides for repetition, and it does provide all the 4 levels of learning experience up to patient safety. Just a little correction to my disclosures. And this is where I'm from, so thank you.
Thank you, Dr. Konia. We have a few minutes for questions.
Thanks, Mojca. That was great. I would like you to comment on the simulation center model versus doing simulations in your own clinical area. I would say that even if we lived on the East Bank and you had this beautiful new building, we would still want to bring the simulators to our emergency department because it's our environment and that's where we're going to do it.
I agree with you completely. I think there's a place for both. I think the intent of one and the other is different. If you're doing it in purely simulated environment, you're probably trying to reach the level of competence or maybe a little bit of operational performance. If you want to really demonstrate your ability to transfer into higher levels of competency, then you will have to do it in the environment. If you want to understand your teams, you have to move it into your environment. And everything that exists in the simulation world these days is wireless. Once you figure out the frequency that you have to connect to, it's all good. It can function anywhere. It's battery driven, so we can put things anywhere we want. I absolutely agree with you. Doing it in the environment identifies things that you would have never believed will surface. It's really interesting.
That's happened for us already.
Yeah.
I just want to say I really enjoyed your talk, and I'm curious with the new center being built. Both Cindy and I had the simulation center for cardiopulmonary services in the hospital, and we have sought out help and resources. We've developed our own sim room for our department. Is there opportunity at any point? I realize the university versus essentially a Fairview operation, there's not a lot of co-mingling and mixing. And so you have all these sub-sim centers set up throughout the hospital, each requiring resources and money to run. Is there any opportunity to blend our resources together, share the space, share our resources and our knowledge, our equipment, to work together in the future?
I am a strong proponent of that. I think it needs to occur. Unfortunately, as you point out, the communication is lacking. We've tried to reach out to Fairview, specifically to their simulation department, and one of the attempts for more interaction was that simulation of airway fire in the OR. I think we need to keep trying. That thing kind of died as it sort of was associated with some dollars attached to it. I think if we all push for it, it will succeed eventually, because I think the larger environment will push us towards that. But I think, unfortunately, like everything in life, it ends up with dollars. So medical school, of course, says, well, you know, we can support this much. How much can you support? And so it ends up dying, but I am fully supportive, and whatever opportunity I get or hear of, I try to advocate for interactions. And if nothing else, let's say it's so specific that it's really relevant to your environment only, I think we could engage into at least exchange of technical support, which is probably easier to accomplish. And frees up your people. I think there's avenues, and eventually that'll lead to more of an integration rather than the scattered things. And I agree, it's very scattered, and I learn about new things every day when I go to give a talk somewhere. I learn about how much people do.
Yeah. Hi, Mojca. It's Carrie.
Hey.
Thank you so much for all the information this morning. I have what I think is a quick question, but we're seeing more and more fellows come into our program, and they have a strong interest in simulation. How do you suggest we get our fellows involved if so much of it has to be directed to the medical student at a different level?
So there's several ways. There's several ways I try to overcome that problem. If, let's say, there's a need your fellows have that's specific to your fellows, but if we can identify a skill they have that I could use, not me personally, but SimPORTAL could use to help some other learner, there's an opportunity for an engagement. Because I can say, well, this way I don't have to hire a student, basically. And we can, and you know, your fellows have lots of skills. You could fulfill the need for them that's given to us by ACGME that they have to teach. You can very well document the teaching that they have done. We can teach them how to do assessments properly, things like that. So I think it can be a mutual benefit. So if they would like to do something, they can reach out. We've just done this with cardiology fellows. They have a need for TEE, additional TEE training. So we came up with this mutual plan where they have access to the simulator on specific days of the week, every week. They got access to it all the time, and they're going to help us do some of the medical student courses, which are really, it's an hour of commitment on their part. It's not this extensive sort of, I'm going to take fellows away from you for 2 months. So there's opportunities.
Thank you very much. This is very exciting. What I wanted to ask you about was if there's been development or modules that have been put into place for patient encounters that don't necessarily have a technical component, procedural or surgical skill, that can be applied to residency programs, fellowships, where there isn't a procedure being performed, but you really wanted to provide an adjunct to their education for particular patient encounters, how they're dealing with difficult situations or conversations, discussions, those kinds of interactions to kind of get an assessment of how they're doing along those lines.
So there's a number of departments that have developed this type of courses. Any course that happens in SimPORTAL is basically disseminated broadly. So if another department wishes to use a similar activity or modify the activity that's available, they're welcome to do so. Examples of that are ER does a simulation on communicating adverse event. Anesthesia does that. The intent is for any curriculum that is available to SimPORTAL or submitted to SimPORTAL is available broadly to anyone. We want to teach the same central line skills to every resident. We don't want surgery teaching different than anesthesia, teaching different from ER. We want all of us to have the same principles of communication about, let's say, adverse event. So if you have a specific thing you need, please email and we'll try to find an activity that fits your needs. We have access to standardized patients through the AHC Sim Center, which can serve as patient model. They're trained to provide feedback as well, not just sit there as a patient, but also give their sort of sense of how the resident did. So please reach out and we can try to help you.
Dr. Konia, thanks very much. We look forward to working with you.
Thank you.